This is a quick overview of just a few of the landmark papers identifying general surgical emergencies in the post-bariatric surgical patient. Some of the most common emergency general surgery problems that acute care surgeons are faced with include small bowel obstructions, gallbladder disease, and abdominal pain. These are also very common in the post-bariatric surgery population, but the management is often very different. In this prospective study by Pineda and colleagues, they tried to determine the appropriate management of asymptomatic gallstones before and after bariatric surgery. They looked at those with stones prior to surgery, which was 34% in total, 20% of which was asymptomatic, and those who developed de novo stones at 1 year post-bariatric surgery, which was 21%. The overall rate for symptomatic gallbladder disease was 3.4% at 1 year. Given the low rate of patients requiring cholecystectomy after 12 months, they concluded that conservative management of asymptomatic gallbladder disease in candidates for bariatric surgery is safe and appropriate. In this next paper by Martin and colleagues, all patients who were admitted with bowel obstruction were included from a national inpatient sample. Those patients who had previous bariatric surgery were compared to those who had not. Post-bariatric surgical patients will have more obscure signs and symptoms, and we must be quick with evaluation. The majority of post-bariatric patients required surgery, whereas the majority of non-bariatric patients were managed conservatively. This demonstrates the importance of understanding the differences in this common complication between groups. This retrospective review provides evidence that postoperative bariatric surgical patients, especially after Roux-en-Y gastric bypass, have a much greater risk of closed-loop small bowel obstruction than the usual non-bariatric surgical patient with small bowel obstruction presenting to the ER. The most common cause in the bariatric patient was from abdominal wall or internal hernias, compared to adhesions in the non-bariatric group. They concluded that early operative intervention is often necessary in the post-bariatric patient. And in this final retrospective study by Al-Mansour and colleagues, they evaluated all patients who underwent laparoscopic Roux-en-Y gastric bypass and later developed internal hernia requiring operative intervention. 6.2% of patients required surgery, and the mean presentation was at 25 months. Mesenteric swirling was the most common CT scan finding in more than half of the patients. In conclusion, internal hernia is a serious and potentially fatal complication after Roux-en-Y gastric bypass. Symptoms are often vague and chronic abdominal pain, and aggressive intervention with diagnostic laparoscopy remains the gold standard.